there. Come, traction, 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 traction. Now I think the whole thing starts. So I'll reposition my traction on the prostate, hold that area where I just held it, pull it. Right? Hold it and pull it. Give me the Babcock's. Give me the Babcock's. Now, Babcock's. So now, can you clean up? Babcock's, man. Just clean up once, I think. Yeah. उसको lock करो, lock करो यार. Yes. Now I think having ligated the prostatic pedicle, now I look at not the lateral prostatic artery, which is a descending branch of that, but the rest of the pedicle which is there next to the pelvic wall I want to save. If I go, that artery to be preserved means it's a complete intrafacial dissection, which I'm not contemplating in this patient with a 4+5 disease. Yes, hold it. No, एक minute में हो जाता है इसके लिए. So I'm trying to come down now. Come down, suction there. Now I will not use much of a cautery. I'll use only the scissor to save that whatever tissue which can be saved across. I am much away from the prostatic capsule, I know that. This is only some amount of alar tissue. This is not an intrafacial dissection. This is much away from the fascia. This is the capsule of the prostate, if you can look at. Okay, if I go near to the prostate, then it is an intrafacial. I am much away from the prostate, so it is not intrafacial, probably to certain extent, not extrafacial, but definitely only a interfacial sort of a dissection. Hold it there. So what is happening is the lateral prostatic artery which is there, which descends there, I already cut it here, which descends from this branch from the prostatic artery, prostatic pedicle, will get cut in an interfacial thing. If that is preserved, that is going to be a complete nerve preservation. So this bundle which is there, this is completely preserved. So I am sure, I am confident about, I am confident about my at least pelvic preservation, not ductile functions, but the pelvic nerve preservation across. So that is what I am looking at.
Yeah, I think,
you look at the
Mallikarjun, you have very nicely explained the same thing. And Dr. Gupta's comment earlier was to look at the prostatic artery.
Anish, one more point I say. Anish, one more point. This is puboprostatic muscle which covers the urethra completely. This is the puboprostatic muscle. Saving that puboprostatic muscle is of utmost importance for good continence. There are two muscles which are going to be there. Puboprostatic is nothing but an apron of the external sphincter which acts as an apron. It's an extension of the levator and a muscle. So that preservation is always necessary. So these 2 points which are going to be there at the apex of the prostate are going to be necessary for preservation of the continence. So I think I opened up, see, this is the apex of the prostate which is already come. This is the urethra which is seen here. This is the puboprostatic muscle. Some amount of the neurovascular bundle which is there. I didn't use any of the energies here. The surface of the prostate is very clear. It still has some veins on it, so I am not on the intrafacial plane. I am much away from the not extrafacial, interfacial plane. So the extrafacial means this levator ani also, this fascia also is gone, the muscle becomes exposed, and this is taken away. So this is retained, and I am staying near to the prostate, but not on the prostate. This is the lateral prostatic artery, which descends from the prostatic pedicle, which goes all across on the posterior, in the posterolateral direction, which is
right. So that is the point which we should be all very clear. And obviously, intrafascial, I think in our scenario or in our country, I don't think more than 5% or 7% you can actually go to the intrafascial plane. And Vipul, during his demonstrations, has always mentioned that. And he even says that even interfascial is difficult looking at the prostatitis and the issues.